We're so delighted to have Peter Martin and Peter Williams with us today. Peter here from our studio and Pete Williams joining us by link. A warm welcome to International Reflux Day, breaking the silence about reflux.
Pleasure, thank you.
Well, thank you very much.
Welcome, Peter. Great
Hi,
to
how
see
you doing? I'm good, thank you.
How are you?
I'm good, Peter. How you doing?
I'm fine.
Great. We're having a good time here. And before I start talking with you guys, because I'm so eager to do that, I will just say to all of you there, if you have questions during this session, it's possible to put them in the comments field where you're watching from. And in the end, we got like 5 to 10 minutes, and we will try to answer as many questions as possible, or not me myself, but Peter and Pete will try to answer as many as possible.
Sure.
So, Peter, how did you get into functional medicine?
Well, I was driven there by my own bad health. So that was around 10 years ago that I had a total crash. It was a burnout, and I didn't function at all. So, and there was I had a long way back. It was like 2 years on sick leave for burnout. Yeah. So I was depressed, having suicidal thoughts and anxiety. I couldn't even read the paper, But then I tried to many different things, from meditation to walking in the woods, and then finally I decided to experiment with my diet. So I did that, tried a low carb diet, and this was more than 10 years ago, and so many things happened. I got better in so many ways in 2 weeks. So that really propelled me into looking more into this kind of alternative ways to fix your health. And then I found functional medicine. I went to the US in 2014 and did a whole lot of courses. I wasn't really well then, but still I used functional medicine then, and also going forward to heal myself. So that was really my story.
So you were exploring like functional medicine on yourself.
You were not taking help from anyone else. So you like started to get interested in the area.
Yeah, I don't know Pete's history. I'd love to hear that later on. But many functional medicine practitioners, their story going into functional medicine is not an easy one. They were quite forced there by their own health issues, or perhaps health issues in their own family, like children or so. But many people that come into functional medicine also have a kind of almost born with an alternative view. They might have parents that were leading a very healthy life or so. And that's not really my way in, because I spent 15 years of pharmaceutical research, really a hard science, biology. So I'm a medical doctor, but I didn't work that much as a clinician. I did mostly research for 15 years. But when now 10 years ago, when I crashed, then I was becoming a GP, general practitioner.
And you practiced that, meeting patients?
Yeah, I was practicing in a general practice, but I only had 2 years. I was only two years in before I crashed. So, and after crashing, I thought that I would never do medicine again as a clinician, because it was so stressful, and I didn't feel like I could really help people in the way I wanted. But
so thank you for sharing, because you've been, I know myself with that background, so I can recall that. But what's your story behind going into functional medicine, Pete?
Slightly different. I've got sort of two academic backgrounds. I started off as an exercise scientist. I was always interested in sort of clinical applications of exercise to chronic disease, and so that's my original background. I had a very small lifestyle medicine clinic in the central London. And in 1996, one of my pals said, you need to go and listen to this man. He's a guy called Dr. Jeffrey Bland. He's coming to London. He only ever comes once a year, and he's doing a talk, and I think you'd be interested in it. So I did. And that was Dr. Jeffrey Bland, who most people consider the sort of godfather of functional medicine. And he did this amazing day's talk with regards to the heart on fire. And it was really about what we think we understand about cardiovascular disease is actually different. And it really blew my mind away. And that was it. That was 96. And I knew after that day that, wow, how can this be so different, but so clear from a point of view of the medicine and the science that this man has just shown me. So I got involved with the Institute for Functional Medicine in 96. And I suppose my second sort of academic career really has been going down all of the academic pathways, and I certified through them in 2013. So I've sort of been in that functional medicine space for quite a long time now, about 20 years. So that's been my journey. And you know, we've had a functional medicine practice in central London now for around about 20 years. So that's my background. But as Peter says, I think many, I suppose, conventional medics usually come into this area because probably the conventional methods of either treating one of their family members or themselves isn't giving them the answers that they need, and it's not making them well. So I'm not going to use the word alternatives. I don't believe functional medicine is an alternative, i.e., you know, it is presenting alternative medicine views. I think what it's doing is amalgamating the best of both conventional and alternative medicine views to give you a very different picture of how you look after people.
Yeah. And have you two met ever before?
We met on Instagram about a week ago, so that's our introduction.
We might have been to some functional medicine meetings. I don't know, but we never spoken, as far as I know, Pete.
No, but I'm sure we will after this. I'm sure we'll connect.
Yes.
So, what is functional medicine? How would you describe it for someone that isn't aware about functional medicine?
Yeah.
Firstly, I totally agree with Pete that many people think that it's an alternative medicine, but it is not. It's far from the truth. It's actually a development of the medicine we know from the 1900s and so on. So we actually use a different concept. It's a systems biology based medicine where we are seeking the root causes of diseases and bad health. And we do that by treating every individual. It's an totally individualistic medicine where each person we see in a holistic way. So if you, Linn, came to me, I would ask you 300 questions before you came in an app in my practice, and then I'd see you for 45 minutes at least, and then we would map you up by taking a lot of blood samples. You would have to give us urine samples, stool samples, and breath samples to really map you up, your biochemistry, your nutrient status, inflammation, microbiome, your gut flora. And
so if I have reflux, or I think I have reflux, I
come to you and I want to examine everything to make me good again.
Yeah.
So then you run all those tests regardless of what I think I have.
That's interesting because many people tell me that, well, the way you work and I know that not every single practice doing functional medicine is doing it in the same way as we do, because functional medicine is also quite diverse. You understand it's a big area, but the way we do it, we kind of look at people that you are Homo sapiens. Mm-hmm. And we know that Homo sapiens has to have certain values for certain measurements has been within limits. And in the regular healthcare system, you look at those limits like, well, Linn, you are red, you're outside the limit, you are sick. But we are not only interested in the red values, we are also interested in the yellow values, which are not green. So we want Linn's values to
in between as well.
Or is that what you mean? Yeah.
Because those are not optimal. Because this is not about disease, really. This is about building health from within. And when you ask me, so we really map everyone almost the same. But then the treatment plan, if you got reflux, it can be different underlying causes, and we will treat it according to the cause we find in you.
And what about
you, Pete? How would you describe functional medicine? Is it in the same way, or do you see it in a different perspective?
I think I'd probably put just a slightly different view on that. I think everything is correct that Pete has just said. I think if you've gone through the appropriate functional medicine training, I think what it gives you is a new operating system of being able to look at an individual. So you're looking at them from a systems approach. So you're taking into a component of them where you're not just treating the symptoms. So, reflux may be a good example of, you're not just wanting to resolve someone's someone's symptoms. You've got to be able to go, well, why are the symptoms there in the first place? And maybe what we're trying to do there is start working not only just on, making people feel better, because actually you've helped them with the symptoms. It's a question of taking the steps behind that to really come up with, well, why are the symptoms there in the first place? And what is the root cause analysis that allows us to look at someone with, say, reflux, and try and get an understanding of, if we just treat the symptoms, maybe the symptoms are going to consistently stay there. And so until we take those steps behind and actually try and work out, well, what's the root cause of reflux, if we're talking about that, we're never gonna solve a patient's sort of outcomes. So for me, functional medicine is a systems-based approach. It gives you an operating system to look at how you transition around and work with a patient. But very simply, if we're looking out for reflux, I would want to be taking a patient and say, okay, so how can we help you with the symptoms? And then why are the symptoms there in the first place? And that's where you go on that exploration to find out, understand the patient, understand their life, and I get that understanding about what are the prerequisites that may be influencing this patient's reflux. They're highly stressed, they've got digestive issues, etc. And that's where I think, as what Peter was saying before, you need to go and explore those root causes, because otherwise, if you don't deal with the root causes, you may always be having the symptoms.
Yeah. So it's in general, in a summary of that, it's both like digging to the root cause, what is causing, and you do run a lot of tests, and yeah.
But that is the elevator pitch for our functional medicine, is really that we are looking for root causes, and you can do that in many different ways, and you can have different focuses when you do that. But that is really the elevator pitch. But still, there are so many things that we do differently in functional medicine, I think.
But how spread is functional medicine in Sweden and in the UK? We start with Sweden then. How spread is it? Is the general person, are they aware about functional medicine as a practice?
Yeah, it's indeed increasing rapidly now, I would say. But to give you an overview, when I started about 10 years ago, we were only 2 functional medicine doctors in Sweden. So as far as I know, so there was almost nothing, and no one knew what it was about.
You were included in that?
Yeah, I was included. But what happened since then is actually we at FunMed, we've been the clinic that I started in 2014. We've been involved in this. We actually have our own education, FunMed Academy. We've trained 300 licensed clinicians, like medical doctors, nurses, etc. By now, in a video course that we created in 2018. So that's made a dent into the curve, that we get some more clinicians, and I mean, to say something more about the clinic that I'm running, and I'm the CEO of and the founder of Fundamental Clinic. We are the second largest functional medicine clinic in the world, as far as we know. The largest one is Parsley Health in the US, and we are around 40 people now, of which about 10 are doctors, and a growing number of health coaches and nurses as well. So, but I would say that most people still don't know what functional medicine is in Sweden. The US, it's far ahead. I think the UK is ahead. Pete can speak to that.
It'll be interesting to hear.
Yeah. But it's growing rapidly, and it's getting more acceptance. And I'd be happy to talk more about why that is.
And Pete, how does it look like in the UK?
Yeah, I think a similar picture. Where maybe 10 years in front of Sweden. It's really, I'm not going to say it's quite popular. It's certainly probably more known. There are quite a lot of people who have gone through the certification process, certainly with the IFM. And most of the nutrition degrees now in the UK are underpinned by a functional medicine model. So you'll have nutritional therapists and not so much dietitians coming into nutrition underpinned by a functional medicine model. So I think the other thing, I think COVID has massively accelerated the need for just the general population to actually take their own health into their own hands. We've got a real problem with the NHS at the moment. They are just overwhelmed since COVID, and unfortunately it's not working as well as we would like. So people are having to take responsibility for their own health. And I think, you know, again, the role for us, I mean, we're overwhelmingly busy with new patients. And so I think it's time. But I also think it's been accelerated with COVID, and it's also been accelerated with, you know, the NHS being overwhelmed, which I think is a good thing, because, you know, the paradigm is always, if you're always ill, you go to your doctor. And, you know, for a lot of people, they've never taken responsibility for their own health. And I think that's what we're seeing an acceleration of, certainly in the UK.
Yeah, interesting perspective. And as we talk about today, 20% of the Western world population suffer from reflux, according to statistics, which means that 1 out of 5 of your friends has reflux. But reflux isn't really something that you talk about with your friends, and maybe not even the family. You hold it to yourself. But when I say reflux, what is the first that comes up to your mind, Pete?
Belching, burping, heartburn, bloating, gastrointestinal sort of struggles with patients, people taking antacids around big meals, feeling as though they've got a brick in the stomach. It could be anything around those subjects. Stress as well. You know, I think when we're talking about what comes into my mind, and certainly when we're seeing patients, we have a significant amount of patients who have some kind of GI upset that may present itself in some way, shape or form from a point of view of reflux. And obviously that number gets higher once we start dealing with, you know, people who are 50 plus. So I always, as you say, as a functional medicine guy, I'm always thinking not so much about the reflux, but the bigger picture that surrounds it, and, you know, thinking about the root causes. And, you know, for me, there's a very strong relationship with chronic stress and SIBO and reflux. So I'm always thinking about, you know, the symptoms that create, you know, the reflux symptoms, as you say, the acid burn, you know, the heartburn. But then I'm immediately thinking about sort of, well, what are the root causes? And, you know, so, you know, stress is a big one. And stress for me dramatically influences that digestive tract. So I've got all of those sort of light bulbs going off when I think about reflux.
Yeah. And so does the 20% suffering of reflux, is that like, do you see that perspective in your clinic as well?
Yeah, I do. I'd say at least 20%, if not higher. So I'd probably put a higher figure on that. You know, and you know, it's incredibly common. I think it's incredibly common, but it's incredibly common how it's sort of many people, I think many people don't go to treat the reflux until it just becomes more serious. It's almost like, okay, I'll keep on taking antacids, and maybe they've gone to the GP, and the GP's, quite rightly given them some kind of, I wouldn't say so much the PPIs. I know we're going to talk about that later, but over-the-counter antacids to try and just help, which may or may not be the right treatment, of course.
Yeah. So how is it? What comes up to your mind when we talk about reflux from your perspective?
Well, the first thing that comes up in most functional medicine people's heads are the question why, and why does this patient have reflux, and as Pete said, what is the underlying cause? And in my mind, I think mainly of three kinds of causes, except for Pete mentioned also stress, but stress can affect everything, like you said, Pete. So that's really why.
Why? And do you
see, is it 20% of your patients in your clinic approximately or more that suffers from reflux?
Right.
As I told you, we collect a lot of data in our app when people come to us, and we pose a lot of questions about symptoms. So we have like 20 questions about gut function, and some of them are like regurgitation, and I don't know if we got heartburn, but regurgitation, if I remember right, it was 15% of the patients that come to us. So yes, it's a very common symptom, and I think it is, like you say, people don't talk about it, they live with it. Many people do.
So what kind of symptoms do you see among these patients coming in, except for those we mentioned quite a lot there with Pete, but are there any special symptoms that you think about when talking about reflux? And
it's mainly heartburn, regurgitation, sometimes chronic cough, sometimes pain. That's the main.
That's the main.
So we know that prescriptions of PPI medication are steadily increasing. And as an example, I looked at the National Board of Health and Welfare latest numbers from 2023, and one can see that it in Sweden has increased with almost 70% the prescription of PPIs since 2006. So it's quite a lot, and it's mainly more women that get the prescription, or more than men. It's still both genders. But what surprised me really was that it was also the highest increase of numbers that got PPI medication was in children between 5 to 9 years old. So what's your general view of PPIs? And
my general view is that I get surprised and angry every time I see someone that's been on PPIs for 5 years or so with not having an indication, because there are cases where you need a PPI. So please don't just quit your PPI if you take it. Speak to your doctor. There is, for example, Barrett's esophagus, which is a precancerous lesion in the esophagus. But most of the people I see, the patients I see with PPIs that have taken them for a long time, they have no clear indication. They're just continuing. And it's been written about it in the Swedish Medical Association journal several times, pointing to this. PPIs are not supposed to be used more than 5 weeks, and then you should try other measures, and they are for acute care mostly. And Pete, you and I can talk more about what are the downsides to PPIs and why do I get angry when I see this?
Yeah. I've got one question about that later. But what's your view of PPIs in general, Pete?
Well, again, I think I completely concur with Peter there. I think it's the right drug for the right treatment for the right time. Where I think it falls apart is when it's a drug that is being overused for too long. And so there could be some very serious GI complaints or disorders where you need to take a PPI, no doubt about that. But again, on general sort of uncomplicated reflux, that when you're using a PPI for long term, then the chances of that becoming highly problematic in the bigger picture of someone, that's where it becomes concerning for me. So not so much acute treatment, as Peter said. PPIs are great medications. You use them for a period of time. It's just when it's been left. And as you say, you'll have people that see it all the time. People come in and they were diagnosed with PPI. And I said, so when was this? Oh, that was done 10 years ago. Okay, you've been on it for 10 years? Yeah, so that's where I think it's the inappropriate use of the prescription medicine becomes the problem. So I don't think it's the medicine in particular. It's just sometimes it's overused. Its time frame is overused.
The time is used.
May I comment?
Sure.
I even have a patient that is on the patent for omeprazole, the first really successful PPI that was invented here in Gothenburg, where we are today, and developed and made a lot of money for Astra. But he was on PPI, but then he understood that, wow, this is not good. And he was really one of the inventors.
And he came to you.
So it.
He's not my patient.
Oh, yeah, that's sort of, yeah, okay, good in the beginning to use it if it's really drastic and hard to live with, but not in the long term.
Yeah.
So I'm just curious, what do you think? I haven't presented these numbers for you earlier, but it was actually like over 150% more children between 5 to 9 year olds that got a prescription. Why is that in Sweden?
I guess when you say 150%, it's probably starting from low numbers.
Yeah, it is quite a
so
low
it can
number
be
from the beginning, but still.
Can sound a lot,
Yeah.
but still, I mean, what PPIs do is they basically shut down your hydrochloric acid in your stomach, and there is a reason that we have hydrochloric acid in the stomach, and that is because it's so important. It's a part of the immune system. It kills off bacteria and bad bugs, but it's even more importantly starting the protein digestion. It's lifting out minerals from your diet, and if you don't have PPIs, you get a much worse digestion. You don't break down your protein. You can get nutrient deficiencies, and not the least, for example, magnesium deficiency and so on. I don't know, Pete, what is your experience?
So if you don't use
PPIs, or did I get you wrong? No.
Well, I think it's
PPIs,
yeah,
then
shut down the hydrochloric
Yeah.
acid,
Yeah.
and you can't get the first step in your digestion to work, and then that it goes even further down, because if the content of your the gastric content, when that moves further down, it's supposed to the acidity from the hydrochloric acid is supposed to start off and the signaling to your pancreas and to your gallbladder and so on.
Yeah. Interesting.
So how do you look at the development in the UK? Do we have the same development of increase of prescriptions?
Yeah, again, I think this comes back to, I think in general humans are living a more stressful life. I think the lifestyle is probably not as good as we would like, and therefore as a consequence of that, you're going to see more gastrointestinal disorders, with reflux being one of them. The difficulty with that is that from a conventional medicine perspective, you'll go to the doctor who looks like you've got reflux, and he will just be following the national guidelines, and then that will generally give you a PPI. So I don't think that structurally is wrong. I think where it becomes where PPI becomes long term is understanding the long term effects of shutting gastric acid secretion down. And as Peter just alluded to, the problem you have is that you really do need a stomach that has optimal acid levels, because it's there to do two things. It's a killing zone for stuff that shouldn't go any further. So bacteria, for viruses, etc., for parasites, that's one of its main job. And then of course you've got the other aspect where it is liberating vitamins and minerals into your body. So you need optimal stomach acidity to make sure you can liberate calcium, magnesium. And again, some of the, particularly B12, it's well noted in the literature that long-term PPIs may lead to B12 deficiencies. Now, if I've got a 60-year-old patient who is maybe at risk of dementia, and then they're on a PPI because they've got reflux, I've really got to think about, well, am I going to have problems with B12? And of course, one of the manifestations of a low B12 level could be, something that induces dementia-like symptoms. So this is where you've got to think about the bigger picture from a point of view of not just reflux, but its systemic effects. And as Peter said, is that if you don't have enough optimal stomach acid, then it changes the way the whole signaling process of the digestive aspect works. You need to have an optimal bolus of food that has an optimal acid secretion, so that when it comes out the stomach, the pancreas gets the signal to say, okay, we need to continue the digestive process. So shutting down stomach acid secretions influences the rest of the digestive process. And so what you end up doing is trying to deal with one symptom and then creating potentially a lot more problems. And I think that's where functional medicine is quite good at thinking about understanding the bigger picture. Now, again, with lowered stomach acid, also what happens is sometimes the bolus of food sits longer in the stomach. And of course, then the food gets more chance to ferment. And then we can have a sort of gas buildup that actually influences the lower esophageal sphincter. And therefore, you can reflux back simply because of the PPI, the sort of longer term effects of the PPI, because there's not enough stomach acid. So look, I think, as I said to you, I think what's clear on this conversation is no problem with PPIs, no problem with the method of action. They're actually in several cases, they're absolutely crucial. But long term, it maybe becomes more of a problem. And that problem, as I say, are the longer term risk factors with regards to everything, with regards to maybe digestion that doesn't work so well when you're on a PPI.
Peter, you had something you thought about.
And thank you, Pete. And I just think we need to also point out one thing, and that is the rebound phenomenon. I
was going to talk about that.
Yeah,
it's really a situation as well.
Yeah, because then many people wonder. But I
explain what is a rebound.
Yeah, it's really when people try to quit PPIs after a longer time of use, then the body starts to make hydrochloric acid again, but it might make a little more than you really are prepared to.
Or need.
Because you've been blocking that.
Yeah.
So the body is, of course, trying to get past the PPI, but it can't. But when you take off the PPI from the system, there is too much acid, and you get a rebound. You get more symptoms. You feel worse, and then you think that, oh, my reflux is even worse. My symptoms are worse. I need the PPI, which is often not the case, because, and the way to handle that is to titrate down your dose over a longer time, for weeks, sometimes months, but many times a few weeks are enough. You have to just guide your patients in how to do that in the right patient, that you're quite sure that they don't actually need the PPI.
So if I as a patient feels like, okay, no, probably some viewers today have been on PPIs, antacids, medicines for a long time. What should they do then? Should they contact their doctor and consult how to do this? Lowering of the
first thing is to understand, why did you get the PPI in the first place? And are you one of those patients that really need a PPI? But educate yourself and contact your healthcare provider if you can, the one that prescribed the PPI. If you can't find that one, find another one and have a discussion about this, because this I mean, it should be known by every doctor that this is the way it works with the rebound, and you have to titrate it. So get some help in doing that. It could really change your life.
Peter, are you also helping patients with this at your
Yeah,
clinic?
I think it's clear it's a well-known phenomenon. Sometimes, as you say, if you shut certain aspects of the body down, it goes on holiday, and then suddenly you take it away and, oh, I've got to work again. So I go slow would always be our recommendations on that, and obviously on an individual basis. But it always comes back to, have we dealt with the root cause of why the reflux is there in the first place? Because you may have been on a PPI that suppresses the symptoms, and generally if you come off it, the symptoms just come back because you've not dealt with why the symptoms were there in the first place. So I think that's what I'd always be looking at. But I think rebound reflux from PPIs, I think, is a well-known phenomenon. And again, your GP should be really you guiding well on that, as in take your time, come down, see how you feel. And you may have to go back on PPI for a little bit of time. But I think this comes down to, it's making sure that you're with a health professional, a GP, a doctor, where you've had that conversation. For most people, they're not even aware of this conversation. They're not even aware of this literature. So I think the psychology of saying to a patient, look, you know, we're going to start bringing you down on the PPI, and it may not be a perfect road. You might have a little bit of reflux. So the psychology then means that the patient at least has some understanding that there may be some sort of good days, bad days as you take them down off the medication. So I think it's, and again, I think a lot of this is that clinicians don't spend enough time with their patients to be able to get them to understand the bigger picture about what's going to happen, what may happen, and that's okay. And we'll work with it. And I think that's a big difference between, certainly from, you know, if you look at an NHS GP who are amazing, but they get 8 minutes with a very complex patient and they can only deal with one thing. They're never going to be able to have that conversation. So I think one of the key things about private functional medicine, if you like, is that you get time to have this chat. You get time to say, well, look, here's the things we've got to think about, and here's what may or may not happen. But at least the patient is prepared for it. And that psychologically changes the landscape from a point of view of the patient's journey.
And that comes also to
my next question, because I understand you, Pete, are using the neuromuscular training device IQoro, treating patients with reflux. Would you like to tell us more about that?
Well, I think as a piece of kit, it really ticks my boxes because, as I say, my original academic background's an exercise scientist, and you know, I'm very much into the aging and longevity research, and really the biggest hitters on aging and longevity are all the exercise related, the fitness related side, or the musculoskeletal side. And what I like about the IQoro is that it is a very simple piece of kit that actually works on the neuromuscular aspect of how we swallow, how our digestion works. And so for me, it sort of fits very much into, you know, as we age, we lose muscle mass, we lose fitness. And very simply, I feel as though there's a strong component to reflux with regards to things age. You know, when we're looking at, you know, the architecture and the structure of the muscles of the way we swallow, both from a voluntary perspective and involuntary perspective, they age. And so what I believe IQoro is doing, well, I think what it's doing, it's working on how the brain communicates more effectively by, number one, the way we swallow, but number two, I think the way the nerves communicate with some of the muscles that shut over the stomach in particular, so that you don't get a reflux back. And of course, this comes back to the whole point about reflux. Is reflux about, you know, is reflux really about humans producing too much stomach acid? I think the answer to that, based on the literature, is no. What it is, it's maybe about actually the sphincter muscles that should shut above their stomach don't shut effectively enough, because that neuromuscular signaling is maybe not as good as it should be. And so we've had amazing success with IQoro. I don't think we haven't had a patient where it hasn't had some very significant changes. And we've had, you know, particularly we've seen quite a lot of reflux with long COVID patients. We've had a young guy at the moment, and within 2 weeks, he was able to come off his PPI. So I'm not suggesting that everyone has the same journey, but there's no side effects. It makes complete sense from a point of view. It's more about neuromuscular efficiency, and we've just had really, really good results. It's cheap, and it's easy to do. We get them to do it after you've cleaned your teeth. You should do it 3 times a day, but we tend to get people just to do it so that it's after they clean their teeth, and it's 30 seconds every time you do it. So it's been, I never usually say this because usually it's sort of not let down, but sometimes products or devices are never quite as good as they should be, but it's been great. So pretty much we use it on everyone, and it generally gives us really good returns. So we've been really pleased with it.
Have you heard before you met us? Now we invited you, but had you heard anything about IQoro before?
Yeah, I did. And my experience is not as vast as yours, Pete, but I spoke to some doctors at our clinic, and for sure there are patients reporting good results with IQoro. I like the perspective that it's neuromuscular training. Doesn't seem very dangerous to me, and it's cheap. It's non-invasive. I mean, I like the concept of it, but I need to learn more. And the way I look at reflux, the way we treat reflux in our clinic is one thing is SIBO, is small intestinal bacterial overgrowth, where you can get gas that pushes up. So that is an important thing, and more than half of our patients have positive SIBO tests when we do that. And the second one is that you can have low stomach acid to start with. And the third thing is that there is a motility issue. There can be just motility, or it can be muscle strength in the esophagus and the gut overall. So, and there IQoro seems like a very reasonable training device for me.
Yeah.
And I have a few questions, and then we have actually got lots of questions from our viewers to you guys. Wow. So we'll get into that. But I have 2 more questions for you guys. So what will it take, in your opinion, Peter, to stop the silence about reflux and the symptoms around it?
I think we're doing it right now. We are talking about it. We are lifting it up in public. So if you are experience reflux, perhaps you should talk more about it with your peers at your workplace, and ask questions about it. Do you ever experience it? What are the problems that you face? And also, there are ways to treat it. Don't just go with a PPI. That is not a healthy alternative, not the first alternative for reflux.
And what would you say, Pete?
I'd probably say this. I think there's probably 2 things on this. I think, again, this comes down to maybe how a traditional conventional medicine would look at reflux. And then obviously there's another way that you can look at reflux, and that's what we're talking about. So again, I think there's always I look at reflux from a point of view of, if you're going to go to the doctors and they give you a PPI, it may address some of the symptoms, but whether that's addressing the root cause is a very different matter. And as I said to you, you might suppress the symptoms, but the mechanisms that are driving the reflux are still there. So I think it's just a bigger and greater understanding of that. No condition generally has one intervention that solves it. It's a question of understanding that there could be multi-systemic influences with regards to why we've got reflux. So my question wouldn't be, let's not just treat the symptoms, let's think about why it's there in the first place. And so that would be just, again, expanding a deeper conversation with regards to just, what is reflux? So not just symptoms, but root cause as well.
Yeah. Thank you. I think we actually go directly into the questions from our viewers. So I'll just pick them up here in a second. Sorry, the first question here is from Geoff Arnold. After gastroscopy, I was diagnosed with gastritis, a small area of non-dysplastic Barrett's, and put on omeprazole. I self-started IQoro 4 months back. How would you deal with my case as functional medics? And maybe that's a question for you, Pete. Did you hear mine?
I think what I would say on that one is that anyone who is looking at more serious potential cases, which this one might be, I think they would have to go through the conventional routes from a gastro perspective. So, you know, for me, I think what's got to be careful from a point of view of me as a functional medicine practitioner is that you've got to be able to understand which are the more serious presentations and which aren't. Now, this looks like a slightly more serious presentation, but I think, again, I would be trying to look at this from a point of view of what is the gastroenterologist saying, and how can we work with them to try and look at this issue. This wouldn't be an issue that I would look at and want to treat, because again, I think this would be one where I would be going with what the gastro is telling us based on the case presentation. But are there other aspects on this that we've talked about that this patient may not think about? They're using the IQoro. Is that helping? You know, are there aspects of their diet that they might want to think about that might be irritating their position as well? I think there's a sort of, you know, there's a conventional medicine look at with more serious cases, but there's also a functional medicine aspect that can go around it. I mean, it'd be interesting to see what Peter thinks on this one.
Yeah. I agree. We have a saying that is first do good medicine, then do functional medicine. So you can't just pass that stage. Functional medicine is not good for everything. But as you said, Pete, we are very happy to work together with a gastroenterologist that can take care of the seriousness of this disease to actually see if we can reverse things. Because in functional medicine, we can reverse many things that we can't even explain why they reverse, because we get the body, this human being, their lifestyle into shape, and then things are reversing. But we can't just count on that. We have to have the gastroenterologist there that can really look at the Barrett's esophagus in this case, and yeah, so that's my answer.
Yeah, so I think we should make it clear. I think, you know, me and Peter aren't gastroenterologists, and there's a component of where functional medicine for generalized reflux in the general population, not a problem. But when you start getting more serious, complicated cases like this one, then you have to be going through the conventional medicine route, but it would be helpful if there's a functional medicine approach around that. If this came to me, I would refer them straight on to some of our gastroenterologists that we know. Yeah. And this is probably a case where omeprazole completely is the drug of choice. So that doesn't mean to say that reflux per se can't be helped from a point of view of functional medicine, but this is definitely a case presentation where you would need, you know, a gastroenterologist and maybe a functional medicine practitioner with them as well.
Yeah, thank you for good answers there. And I got a question with me from this morning session, actually, from customers coming visiting us here in the studio. And she asked if you have a low production of acids, stomach acid, could that affect the lower esophagus sphincter?
Mm-hmm. That's a very common reasoning in functional medicine. And I think there are also studies that reflux is not only caused by too much stomach acid, but also by too little, which is called hypochlorhydria. So yes, and for sure, I've seen many patients that have reflux symptoms, and you give them actually more hydrochloric acid, more as a supplement. I think it's not that well known in the general public in Sweden that you can do that, but our patients do it all the time. So you take several capsules with meals to elevate the hydrochloric acid in the stomach when you have food there. But you should not have any symptoms from that. You shouldn't feel awkward or warmth or anything. So, no, there should be no side effects when you do that.
But could that, like,
in that case, because would that lead, if you have too low acid, would that lead to acid reflux?
Yeah, I think the reason is that if you have too low acid in your stomach lining, then the lower esophageal sphincter, that's a hard word in English, Pete, you have to help us here. If you have low stomach acid, the sphincter doesn't really react. It doesn't understand that it should really keep tight there. Yeah, so.
Yeah, I think there's emerging evidence on that. I think two things. Low stomach acid and high stomach acid presentations look very similar. So, and I think this is the conundrum. A lot of people may go to the doctors with what they think is high stomach acid, but it's actually low stomach acid. And so they get a double whammy. They've got low stomach acid and they get put on a PPI, which is almost like an amplification of potential problems longer term. If you can also
how
think
do you figure out?
Well, you don't. Well, this is the problem, is the presentation is very similar. And I think what happens with lower stomach acid, when a bolus of food sits in the stomach, it takes longer to come out of the stomach because it's still trying to be broken down. And so you can have quite an increase in the fermentation process, which of course creates gases. And then that gas can either go down or it can go up. And if it goes up, sometimes the pressure is so much that it pushes the esophageal sphincter open, and then you get a reflux. And I think that's becoming more and more validated in the literature as far as a process. And that's the difficulty, of course, as I said, when I think about life and I think about everyone, is that it makes sense that, or it makes theoretical sense that the more stressed you are, the more likely you're probably going to have lowered stomach acid. Because when you think about it, it is incredibly energy dependent to produce stomach acid from nothing. It takes a lot of energy of the body to do that. And of course, if that body is fighting fires or every day because it's in a fight or flight mode, you're potentially less likely to produce stomach acid. So I think what I'm trying to say is that my first port of call is that it's not that you don't get individuals who just produce more stomach acid, but it's certainly not a big proportion, as opposed to most patients who come in generally have lowered stomach acid. And, you would see stuff like, certainly, one of the first questions I would ask them would be, does it feel like you've got a brick in your stomach when you've eaten a meal? Are you seeing a lot of undigested food in your stool? These would be some of the questions that would point me more to, think about what Peter was saying with regards to, you can use betaine hydrochloride and you can give them a little bit and see whether they respond positively or negatively to that. So there's various mechanisms that you can sort of trial it out, as Peter just alluded to there. But the presentation is very similar.
Interesting. And I got another question here from Emilia. Are high stress levels connected to hiatal hernias type 1, and how/why? I know about food and stress management. I study functional medicine, but could need some tips for mechanical problems of hernia. I, for example, just learned that caffeine impacts lower esophagus sphincter, and it has helped me a lot to lower my caffeine intake. Do you know anything about anything else that impacts the function of the lower esophagus sphincter, and so on? It was a long question, so I think we go for the first one. Are high stress levels connected to hiatal hernias type 1? How, and if in that case, why?
I don't know is the answer to that. So I can't give any judgment on that one. I certainly think there are foods, which would be the foods that, the like chilies and stuff like that may exaggerate reflux problems. And I'm not aware, again, it's new to me, I'm not aware that caffeine has an impact on LES, but clearly I do now. So, difficult from a mechanical problem. I think the IQoro and I think just the explanation of a hiatus hernia, what's really happening there is that actually a bit of your stomach is coming up through the little hole in the diaphragm. And the diaphragm's that big breathing muscle just underneath the ribs. And sometimes when you know, and again, this could be because people are inactive, they're not very active, their breathing muscles aren't good, they don't have a strong diaphragm. And actually the mechanical aspect that we talked about with the IQoro is really, really good at trying to retrain those muscles and that neuromuscular component that, you know, the whole reason why the IQoro was developed is really, again, for people predominantly with hiatal hernias that cause a reflux. And so that retrains things to push the stomach back through the diaphragm and gets rid of the hiatal hernia. So it'd be good to sort of know from IQoro about that side, because I know that's one of the key aspects with regards to what the training does. It really is. And this
actually, sorry for interrupting you, Pete, but this will actually be the last question that we could take here today. So I just want to give you a big hand for being here together with us, joining us for International Reflux Day, breaking the silence. And a huge thank you. It's been so interesting to talk to you too. We could have gone on forever.
It's been great fun meeting you, Pete, as well, and everybody out there. Have a good day.
Pleasure. Thank you so much for bringing me on. That's great.